Hi, my name is Lauren Klein, and in this video, I'm going to discuss my responses to these case studies for Unit 4. To start off, case study number 2 discusses a 4-day-old infant with a presumptive diagnosis of phenylketonuria. First, I'm going to explain which amino acid may become essential as a consequence to phenylketonuria. The hydroxylation of phenylalanine by phenylalanine hydroxylase and the cofactor BH4 results in the production of tyrosine. When there's a deficiency in phenylalanine hydroxylase, or BH4, the clinical presentation of phenylketonuria occurs. The deficiency results in the accumulation of phenylalanine. As a consequence of accumulation of phenylalanine, tyrosine becomes the essential amino acid. This means that the tyrosine must come from an exogenous source. Phenylketonuria is a birth defect that is caused by an autosomal recessive inherited disease. This is why the family might have not known that they were carriers of the trait. Phenylketonuria is caused by mutations in the phenylalanine hydroxylase gene, or PAH. The mutation causes the deficiency in phenylalanine hydroxylase, which is responsible for the hydroxylation of phenylalanine to tyrosine. When phenylalanine hydroxylase is deficient, the body cannot break down phenylalanine, causing an accumulation. Phenylalanine accumulation can be induced by high-protein foods. The PHE dietary restriction therapy was vital to the newborn's well-being. The dietary restriction prevents the accumulation of phenylalanine. Without the dietary restrictions, the infant could be at risk for mental disabilities and neuropsychological complications such as autism, seizures, and motor function disabilities. Some treatments include tetrahydrobiopyridine, which activates the activity of phenylalanine hydroxylase, which results in decreased plasma phenylalanine levels. The BH4 loading test allows for the differentiation between newborns with increased levels of phenylalanine with a BAH deficiency and newborns with a BH4 deficiency. On the newborn's 5th to 6th day of life, phenylalanine levels are determined. When levels of phenylalanine are elevated, the newborn is hospitalized and a BH4 loading test is performed. Plasma phenylalanine levels are taken before the BH4 solution is given to the patient, and then 2, 4, 6, 8, 12, and 24 hours after the solution was given. The BH4 loading test reflects the effectiveness of the BH4 loading and allows for doctors to differentiate between classical PKU, mild PKU, moderate HPA, and biopyridine deficiency. If phenylalanine decreased by at least 30%, the treatment was beneficial to the patient. In the chart provided, it is evident that patient B's alanine levels significantly decreased 6 hours after the BH4 administration. This indicates that the patient was responsive to the administration of BH4. The responsiveness indicates that there's a deficiency with the cofactor BH4 and allows for the patient to be treated with the BH4 cofactor instead of being on such a restrictive diet. This offers the patient the ability to consume more of a normal amount of protein. Patient A is unfortunately not so lucky. Patient A's phenylalanine levels did not decrease in response to the BH4 loading test. This indicates there's a deficiency in phenylalanine hydroxylase, which cannot be treated with a supplement. When a patient does not respond to BH4, they are more at risk due to their higher levels of phenylalanine. This means that the patient is going to have to be on a PHE dietary restriction. The PHE dietary restriction involves a restriction of high protein foods such as meats and eggs. Now, I would like to discuss case study number 3. This case study involves a 47-year-old male who presents with severe pain in his right toe. After labs were drawn, the patient was diagnosed with gout. The 47-year-old man who presented with severe pain in his right toe was diagnosed with gout. Gout is a form of arthritis that is caused by buildup of plasma uric acid. The patient's lab results indicated a low level of uric acid, 215 milligrams per 24 hours. The normal range of urinary uric acid is 413 plus or minus 78 milligrams per hour. The patient's plasma urate levels were increased at 10.5 milligrams per 100 milliliters. The normal range of plasma urate levels are less than 7 milligrams per 100 milliliters. Gout is a form of arthritis caused by a buildup of plasma uric acid. When there's a flare-up, uric acid crystals form around the joints as a consequence to an accumulation of uric acid. Gout is typically seen in the joints of the big toe. Gout can present in 3 various ways: decreased salvage of purines, overproduction of purines, or an under-excretion of uric acid. First, the decreased ability to salvage purine nucleotides causes an accumulation of uric acid. Lesch-Nahm syndrome is caused by a deficiency in the enzyme required for purine recycling. This enzyme is hypoxanthine guanine phosphoribosyl transferase. A patient presenting with gout caused by decreased salvage of purines would present with joint inflammation and neurological symptoms. The decreased ability to salvage purine nucleotides would result in the increase of plasma urate as well as an increase in urinary acid because there is no deficiency in the excretion of urinary uric acid into the urine. This patient's gout is not caused by a decrease in the salvage of purines. As seen in the table, the patient's uric acid levels are decreased. As talked about previously, a patient that presents with decreased salvage of purines would have increased uric acid levels. The overproduction of purines occurs when there is increase in ribose 5-phosphate. Von Gehrig's disease causes a deficiency in glucose 6-phosphatase. Glucose 6-phosphate is produced through gluconeogenesis or glycogenolysis, and the glucose 6-phosphate is trapped in the cell because of the deficiency in glucose 6-phosphatase. The glucose 6-phosphate is then oxidized through glycolysis or through the pentose phosphate pathway. In the pentose phosphate pathway, The ribose 5-phosphate is required for the synthesis of the PRPPR activated sugar. When glucose 6-phosphate is oxidized through the pentose phosphate pathway, this greatly increases the production of our ribose 5-phosphate, which leads to an increase in purine bases. Since the increase in substrate leads to an accumulation in the activated sugar, ribose 5-phosphate, this increases purine production. In lab tests, this is seen in an elevation in uric acid. In this case study, the patient presents with low levels of uric acid and high levels of plasma urate. This leads to the conclusion that the patient's gout was not caused by an overproduction of purines. Lastly, gout may be caused by an underexcretion of uric acid. The underexcretion of urinary uric acid is the best explanation for the gout for this patient. The increased plasma urate and decreased urinary acid levels are indicative of the diagnosis. The decreased uric acid level indicates there's a deficiency in the process of excreting uric acid into the urine, causing the urate to be retained in the plasma, causing an accumulation of urate. The patient also indicated that he recently switched from diet soda to regular soda and drinks approximately 4 to 5 liters per day. The impact of the patient's dietary modification on the presentation of gout is substantial. The primary sugar in most sodas is fructose or high fructose corn syrup. It has been found that an intake of high amounts of fructose containing foods or beverages affects the levels of uric acid in the blood. When large amounts of fructose is metabolized, fructokinase phosphorylates fructose to fructose 1-phosphate very quickly. This results in the accumulation of fructose 1-phosphate and a decrease in phosphate. Catalase B breaks down fructose 1-phosphate into dihydroxyacetone phosphate and D-glyceraldehyde. The phosphate levels are decreased, so ATP, ADP, or AMP production is limited. Phosphate is being used up in the metabolism of fructose and is unable to assist in other pathways. In this case, the ATP that is now limited due to the decrease in phosphate is necessary for the synthesis of nucleotides. The decrease in ATP causes a decrease in the ability to salvage purines, causing hyperuricemia.